in the system, they have to be rostered and has to be taken care of. But there's certainly a new breed of physician coming out now. And I should only talk about physicians, because it's a system of primary care, physician assistants, nurse practitioners. We need them all to work as a team. So I think that's the key to primary care, is everybody working together as a team. But certainly our medical schools graduates are increasing. There is some concern that we've gone past the bar and it may have to start decreasing, but it would be nice to have physicians start retiring at 55 and 58 and be quite comfortable, so and not being burnt out. Increased number of physicians returning from abroad, as well as an increased number of international trained medical students. So certainly when I, again, started negotiations in 2004, we had a net exodus of physicians leaving Canada, going to the United States. We had the brain drain, in the sense that we had some of our top scholars, our top academic doctors doing transplants, doing heart and lung transplant. They'd gone to Pittsburgh, they trained in Toronto, gone to Pittsburgh, they'd gone to California, they left Canada. So we sat down at the table again with them and said, what can we do to keep our smartest, our brightest physicians in Canada? And they said, we need to be appreciated, we need to give them more our time, we need to actually have a program of specialty care. So we sat down again with Ministry of Health, and we developed what we call the Academic Medical Steering Committee, and we put a lot of money into academia and medicine. And what happened again, we're not losing those physicians anymore, we're training the best, we have some of the best residents in the country, but we do share in the United States. I mean, we back and forth. You know, we send some a lot down to Pittsburgh, a lot down to California, a lot down to Cleveland, but we get them back. And there's an exchange now back and forth between, because there's not that big discrepancy in pay. So it's working out really well for both sides. We don't get the physician drain, and I don't think we're seeing a lot of the American physicians, the high-skilled physicians also. Next slide. So Ontario is the leading leader in primary care innovation in North America, and they are. I mean, we've actually moved primary care because we think that is the foundation of affordable medical care in the world, and I think all the data supports that field. So certainly, but it was a difficult transition because physicians were still suspicious of going off fee-for-service. So we gradually got physicians there by transitioning them very slowly. We initially sort of formed a family health group. The family health group was, you began to capture your patients with a small capitation fee, $2 a month. You sign these patients up, the physician would get $2 a month. But basically most of his service would come from fee-for-service. But then we also opened up the family health organization, which was a larger fee per month and less fee-for-service. And all of a sudden, as 4 or 5 years went on, next slide, you'll see a graph here. As you can see, the fig is the light blue, which is more fee-for-service than capitation, and the dark blue is more capitation than fee-for-service. And you can see how the full group is more capitation, and actually their satisfaction with practice has increased by 80% over the past 2 years. So they're really happy with the work they're doing, and the patient satisfaction is also happy with the work they're doing. So we've made that transition, and we're going to think over the next 4 or 5 years to be little in the FIG model, which is called the family health group, and more in the fully capitated model. And how do you do the capitated model? Not all services are capitated. There's a definition. There's about 132 defined capitated services, but there's still things outside the capitated that you do fee for service. So there's again, it's a combination, it's a blended system. Next slide. And even surprisingly, the patients caught on. The patients want to be connected to a family doctor. So out of 13 million people we have in Ontario, 10 million now are rostered to a family doctor. I mean, it's not 13 million, we still have a little bit of ways to go, but 10 million of patients in Ontario can classify them with a family doctor, and that family doctor is responsible for the care of that patient. And what we've done to refine this also, we put more accountability measures into it. So we can track them now. We can track how many patients the primary care doctor is seeing, how long their waiting list is, and if there's problems, we actually, as a group, it's group dynamics, we form our group. If we see one physician not serving the population, we sit down in the group, look at our numbers and say, Dr. Kennedy, you were away for 3 weeks. Your patients were seeing me in our after-hours clinic. Where were you? Because you're getting paid the same amount of money as I am. And there's group accountability, and you want to perform within your group. So so we formed this governance organization and these family health organizations where the group mentality is to make sure that you actually are pulling your load. And that is a very important thing. You don't have that isolated physicians out there billing the system, but not responsible for the system. So what we're trying to do, and it's never been done in many areas, primary care has never been a system of care. It's been usually everybody on their own or small groups on their own. This actually is organizing primary care that you're accountable to each other as physicians, but you're also accountable to a group of patients. And you really have to, and you can follow the numbers, and you're accountable to your colleagues each and every day. And if many of your patients are going to emergency because you're not accessible, the emergency doctor gives you a call and say, Dr. Kennedy, where have you been? Well, I've been giving talks in Duluth, but I hope you take care of things. So it is more social accountability, social responsibility, and I think it is better care for the patients, right, how we're reforming primary care. Next slide. So electronic medical records, you cannot do this without data. Without following data, you need the data. And I think that's how you challenge, that's how you win some of these myths out there, is by showing the data, how you can deliver care in a timely way. So the waitlist data that came across the news several years ago, the myths out there that's promoted by many of the people who are against Obamacare, we can actually prove now that these are just myths. This is just scaremongering. 5 years ago, we probably didn't track as well, but now we can track. We can track wait lists in the primary care office. We can take wait lists from when I make a referral to a specialist. I can see how long that's going to be. So we're tracking all this. So the electronic medical record is just great things for collecting data, following data, making changes and corrections in what direction you want to go, but also for patient care. I mean, the patient to interconnect. So if I'm in emergency and I'm seeing a patient there, I connect to the record of a family doctor and I see their whole profile. So it really is better patient care, the electronic medical record, but it's just not, it should just not be in the physician's office. It should be connected to the total system. And we're still struggling with that too. We still got a ways to go in that, but we are making great strides because the electronic medical record is key to looking at health outcomes, looking at accountability within the healthcare system, and moving this system forward. Next slide. So I think that's pretty well all I had to say. I think I spent over my allotted time, but I'd like to thank you. But I will take questions. Great question. So right now we develop these family health teams. And these family health teams, again, are, so one model pays the physicians, the capitated model. But then, depending on how many patients you have in a group with your capitated model, they look at the morbidity of that patient population, and they assign you a nurse practitioner administrator. The government pays. The government pays for that physician assistant. The government will pay for that nurse practitioner based on your patient profile. And they will actually pay the operating expense for the nurse practitioner. Also, dietitians is funded. Mental health workers is funded through the family health team. Now, there's only 200 in Ontario family health team right now because it's getting expensive to run the whole system. They're looking at changing that, but it's funded by the Ministry of Health. But you can also, I have a nurse practitioner in my office, I pay them myself because it's worth it. I mean, I'm out here doing some administration jobs. I have a nurse practitioner working for me, seeing my patients. I'm connected to the electronic medical record. I'm connected to my digital phone. If he or she has a question, he just messages me and I answer it. So I take the advantage of paying them myself. So two ways: the Ministry of Health will pay, or individual physicians will pay. So there's one back in there.
Yes, I was in a conversation yesterday, and I don't know, this is not your expertise, but the quarrel that he was putting to me on the healthcare is, I'm 35 years old, and I don't want to be paying 60% of my income to pay for health care. I hear this from a lot of people. How much are the Canadians paying out of their pocket for health care?
Yeah, good question. I mean, certainly our tax rate, depending on how much income, it's based on income, right? So I mean, our tax rate, I mean, unfortunately, I have a higher income than some, and my tax rate is about 45%. But, you know, the average income in Ontario and Canada, their tax rate is just the same as United States on the average. The employer pays an employee health tax to fund part of the system. It's called, but that's from the employer. It's called the employer health tax, and we used to have patients pay so that what we call an OHIP benefit. That was taken away about 10 years ago because it just didn't seem to be working. We passed it on to the employer. So the employer now pays, and depending on the size of your sort of group, pays an employer health tax. But that just pays for 1/10 of the system. So as far as taxes go, I mean, I can't give you the exact data on taxes, but the tax system in the United States has increased. The tax system in Canada has stabilized, and I think you've actually caught up to us in the average income. Okay, so I mean, from our perspective, taxes are a concern for all of us, but it's not a burden for the average income person in Ontario, and it's not a burden for people who can afford it either. So I mean, and also if you don't have the affordability, if you're unemployed, you don't pay any, but you still get your health care.
What do people do, is insurance sold up there for things like dentistry, plastic, no, probably not plastic surgery, but, and if you need a specialist, do you have to have insurance coverage to pay for that specialist?
Not at all. Our sort of healthcare system, single payer system for the medical need, pays for all primary care doctors and specialists. And hospital care and operations. Now, if, again, as I said before, private insurance, you can get private insurance for the add-ons like eyeglasses, dentistry, medications. Okay, so medications cover for everybody 65 years of age and over, but certainly, and the private medical insurance plans pays for the medication prior to age 65. Yeah, and again, if you can't afford it, there'll be found a way that you can. The Trillium Healthcare Act will actually cover it.
If someone has the added insurance to keep the service, everybody gets the basic, but they have a little extra. Does that give them an advantage to move to the head of the line?
It's called queue jumping, and queue jumping is very frowned upon in Canada. Now, you know, in the sense of the fact, there was just a study done in Alberta where the Calgary Flames hockey team, when they had the SARS outbreak and they had the epidemic out there was actually investigation because some of the hockey teams, some of the politicians were able to go to the front line to get their immunizations. That's been investigated, and now they have a whole act about queue jumping. But you know, queue jumping happens no matter what you do. In a sense, I mean, if you're, you know, if my best friend, you know, comes to me and says, Stu, you know, I got this, so I call my colleague, you know, and so it happens no matter what you do. But as far as queue jumping goes, it really is frowned upon now, actually. But there's no need to do a lot of queue jumping when you have an acute crisis, because if I have somebody with a heart attack or a bad broken hip, or I have somebody I'm concerned about with a cancer, I'll just call my specialist colleague and say, listen, I need help. And we protect each other, and he or she will be seen within a couple of days. So I mean, it's personal contact, right? So we do frown upon queue jumping. You know, I'm not going to stand and lie. It happens, you know, in a sense, you know, so underground. But certainly, it is frowned upon. And just because you have a private insurance, no private insurance is going to allow you to queue jump whatsoever. You can't sort of say, because I got a private insurance, I'm going to see you tomorrow.